Good afternoon. Today I'm going to speak about alcohol withdrawal. So the way the lecture is going to be broken up is I'm going to first of all talk about some background and physiology. I'm going to go through some definitions, and hopefully you'll leave here with a better understanding of both alcohol withdrawal syndrome and alcohol withdrawal delirium, which are two separate processes. I'm going to go over some of the high points about the presentation and differential diagnosis of alcohol withdrawal. Then talk about the CIWA scale, and hopefully you'll leave here with a pretty good understanding of what that is, because we started using that here and we're going to use it more. I'm going to go over some high points about treatment and then end talking about a couple different protocols, one of which is a protocol which we have here in our ICU. A couple fun facts. So the beverage content of alcohol, so basically a can of beer, a glass of wine, and a shot all have about the same amount of alcohol. Actually, wine has the most. The rate of clearance for blood alcohol in the average person is about 20 milligrams per deciliter per hour. Visalgia is the name for hangover, headache, poor sense of well-being, anorexia, diarrhea, being tremulous, and having poor performance overall. 50% of alcohol-related deaths are due to injury. So that's more than cirrhosis, more than hepatitis, more than pancreatitis. So injuries are the most common medical condition for which people with an alcohol problem will seek medical attention. You can see the percentages there are pretty impressive. So 85% of homicides are alcohol-related, and you can see the rest of the percentages fall out. 50% of trauma admissions have a positive blood alcohol at presentation. And they present with alcohol on board, and then they're not able to continue to consume alcohol. And so they may manifest withdrawal, which is brings us to the topic. Last year I did a questionnaire just to kind of give you an idea of the scope of the problem. I sent it out to 170 different trauma surgeons at various level 1 and 2 centers. I got about 50% response, which apparently is average for questionnaires. Over 50% of those that I contacted had treated more than 20 patients for alcohol withdrawal during the preceding year. That being said, at least a third of them were unfamiliar with the definitions for alcohol withdrawal syndrome and alcohol withdrawal delirium. So hopefully the audience today will leave with a better understanding than most trauma surgeons. 81% screen patients, typically with H&P and blood alcohol. In terms of protocols, which we'll end up the talk with, less than half of them had a protocol for diagnosis, but about 2/3 had a protocol for treatment once it happened. And the most common agent used was empiric benzodiazepine. A couple comments about the physiologic effects. The biggest thing, areas that are of concern with respect to the ICU, are the effects that it has on the neurologic and the respiratory status of the patient. Essentially, alcohol affects every aspect, but it's the neuro and the respiratory that's most important. So with neuro, the first thing is you overestimate the degree of injury, because the alcohol is making them seem like they might have a head injury. With the declining mental status, you get medications. So they're intoxicated and belligerent or uncooperative. Then they aspirate, then they get pneumonia, then they get intubated, then they stay in the ICU. So that's from being intoxicated. So then they withdraw, and then they have an altered mental status, so you can't wean them, which in turn leads to trach and PEG and what have you. So those are the two main effects as it impacts ICU care. Other things, it'll affect the cardiovascular system. Because of the peripheral vasodilatation, you require less blood loss to give you hypotension. Blood clotting is impaired. You have less GI motility, so you're more likely to aspirate. Remember that the reason that alcohol gives you diuresis is that it inhibits ADH. And ultimately, for patients that come in intoxicated and then develop withdrawal, the mortality can be up to 3 times higher for those that require operation than those that don't develop the syndrome. So, a couple definitions. So, this is sort of the textbook definition by DSM for alcohol withdrawal and alcohol withdrawal delirium. You can see that they're two separate definitions and pretty busy. To break it down, alcohol withdrawal is defined by the American Psychiatric Association. The key features are that it's a cessation or reduction in, so you can still have a blood alcohol level and withdraw. Heavy and prolonged use. You need to get 2 or more of the list that you see within hours or days. So we'll go over these again, and these come into play with the different scales that we use. So autonomic hyperactivity, tremor, insomnia, nausea and vomiting, hallucinations, the most common of which is auditory, psychomotor agitation, anxiety, and potentially even seizures, which are not focal, which are grand mal. And the key thing about the alcohol withdrawal are that the symptoms that you get are not due to a general medical condition, which you'll see is a common theme that I'll repeat. Delirium. So different definitions. So the big things about delirium is that it represents a disturbance of consciousness, which is basically a difference in the awareness of one's environment or the ability to have attention. It's a change in cognition and perception. It fluctuates, and basically the definition was formalized in 1980 to emphasize that it's the result of withdrawal and not alcohol toxicity. So presentation. About a quarter of alcohol abusers will develop alcohol withdrawal if it's stopped abruptly as it would in the hospital. The manifestations can range from anxiety to delirium tremens. It can start as early as 5 hours after your last drink. The peak typically happens at 48 to 72 hours, and usually it requires about a week to subside. The manifestations you can broadly categorize into four different categories. So the first is uncomplicated early withdrawal. The next is withdrawal seizures, then hallucinations, and finally DTs, which most people incorrectly use to describe any kind of alcohol withdrawal. The first, the uncomplicated, as I talked about, 5 to 8 hours. It peaks the earliest of the manifestations. You get tremors, you get autonomic hyperactivity. The treatment for this is symptomatic, and once again, benzodiazepines are the mainstay for that. Withdrawal seizures can develop in up to a third of patients. They typically start a little bit later. It's generalized seizures, and they're self-limited. The key thing about these seizures is you use benzodiazepines, not Dilantin. Okay, so do not use Dilantin for an alcohol withdrawal seizure. Hallucinations, up to a quarter of patients. The most common is auditory, and there's no clouding of the sensorium, and that's the key distinction between the hallucinations versus delirium. Treatment of these is HALDOL. Delirium tremens, once again, we talked about the definition. It can happen in up to 5% of people. This typically manifests later than the other categories. It's predicted by the Cage questionnaire, by heavy use in particular, by previous history of seizures or DTs. And the concerning thing about this is that your likelihood of developing DTs can be exacerbated by the benzodiazepines you give for the other three. A couple more words about DTs. So it's severe neuronal hyperexcitation. You got a catecholamine storm. Remember, these patients are febrile, they're tachycardic, they're tachypnic, they're hypertensive. They develop delirium, which we talked about, and the mortality can be up to 15% untreated versus 1% for those that are treated. So the differential diagnosis. So if they've got a mnemonic to remember things, there's a lot to think about. So I watched death was the sort of catchiest one that I found. And pretty much this list encompasses everything. So the big things to look at are, number one, it could be infectious and sepsis. You can get it from pain. Any kind of metabolic syndrome can cause it. Trauma itself and the bleeding and subsequent shock can cause the symptoms that might make you think they're in withdrawal. There's various endocrine, toxins, vascular. A lot of the medicines that we give can give it: beta blockers, cimetidine, insulin, steroids. Once again, you gotta rule out this differential diagnosis. So that brings us to the CIWA scale. So another busy slide. You can see this is a difficult, lots of information in this topic. So CIWA stands for Clinical Institute Withdrawal Assessment. And you can see here, pretty busy slide. To break it down, this is a scale that was developed primarily in detox centers. And beyond the problem that they needed to be detoxed, these are generally healthy patients. There's 10 signs that you go through, and the points you get assigned per sign ranges between 0 and 7. And so the minimum is 0, the max is 67. Right here I have the list of the different 10 signs that you look at. And basically, the key thing about these is this is the same signs that we talked about before. Okay? The signs that are, and the questions, if you will, that you ask, that you look at, asterisk represents those that require the patient being able to communicate, which is a key problem with our patient population. So if you can't talk, and the patient can't talk and answer questions, the CIWA scale is probably not applicable to them, which we'll talk about. So 7 out of the 10 things we look at in the CIWA scale require intact verbal communication. Basically, the idea is you categorize the severity. By doing that, you predict the likelihood of developing further complications, seizures, delirium, and you treat based on the CIWA score. Drawbacks that go along with the score are that it's subjective. So you've got the nurse asking the patient. So there's 2 places that you have a subjective answer. It requires a lot of training and experience, requires repeat evaluations, very labor intensive. The other thing that comes in is that this is not very well studied in critically ill patients. So as I talked about before, these primarily were the CIWA scale, which is considered of the scales that are available, the best. It was developed in healthy patients who were detoxing only. And because of it, there's the propensity for inappropriate or overuse. Last year in the Mayo Clinic proceedings, Hexel looked at patients that were treated for alcohol withdrawal using a symptom-triggered therapy. They sampled a quarter of those patients, so a total of 124. And the premise of the study was that to have alcohol withdrawal, you've got to have recent alcohol use. So if you were an alcoholic and used 10 years ago, and then you come in the hospital, you can't have withdrawal. Given what I just said about the need to have intact verbal communication, you need to have that. So you need those 2 criteria to use CIWA and symptom-triggered therapy appropriately. So breaking it down, those 124 patients, only 60 of them met both criteria. So less than 50% of the patients that were getting a CIWA scale, getting treatment based on that, actually met criteria. 9 weren't able to communicate, 35 didn't have any recent alcohol use, and 20 had neither. They looked at why somebody would be treated with the CIWA scale and why they would be inappropriately get put in this treatment group. And they found that chronic heart failure, patients that were post-operative, liver disease, non-metastatic cancer, and those that had some kind of chemical dependencies were the predisposing factors to be inappropriately selected for this, with the post-operative state and liver disease being the 2 most common. And the key thing about this is, as we talked about with the differential, if you're selecting the wrong patient group and you're saying, okay, you've got these manifestations, we're going to treat you for alcohol withdrawal, you're missing the real reason, okay? So the alternative explanations, the main ones are pain, shock, sepsis. But, I watch death. All those things, I mean, it's death is in that word or in that mnemonic for a reason. So you treat them for alcohol withdrawal, ignore the other ones, you're going to do the wrong thing, you can kill them. A couple comments about treatment. So it's not always possible to prevent alcohol withdrawal. You may just have to treat it. The idea behind both treatment and prevention is that you want to keep your patient comfortable, calm, and cooperative. Okay, that's sort of the key words that when we talk about Precedex, those are the sort of the key words that we talk about, key phrases, and we'll talk about that in a second. You want a state of light somnolence. So basically the patient's awake or they fall asleep, but when you stimulate them, they wake up very easily, and they're comfortable. The idea behind this is that you prevent serious symptoms and you prevent complications. And then, of course, the long-term complications. You can break up treatment into 4 main categories. So the first is supportive care, behavioral therapy, nutrition, and then finally drug therapy. So supportive care, you want a quiet, well-lit room, okay? You want to reassure them, reorient them. We have the behavioral interventions, which we may not actually do in the ICU, but the patients hopefully get before they leave the hospital to prevent them from abusing alcohol in the future. Nutrition starts in the trauma bay, IV fluid, giving them glucose, giving them thiamine, folate, multivitamin, replacing their electrolytes. Drug therapy, which we think about most often when we think about alcohol withdrawal, you basically have to look at the physiology and the effects of alcohol. So alcohol potentiates the inhibitory effect of GABA in the CNS. And with chronic exposure to alcohol, you have neuroadaptation. So basically, your GABA receptors go away. Those are the inhibitory. Your excitatory, NMDA, upregulate. And so basically, to prevent withdrawal, you have to give the patient something which mimics the effects of alcohol. And basically, in turn, stimulates the GABA receptors that are left and inhibits the abundance of the excitatory receptors. The mainstay of which is benzos. So there you have a list of all the medications which you could potentially use in alcohol withdrawal. Josh, so based upon that list of drugs, which of these drugs is inappropriate for use in alcohol withdrawal?
Based on what we just said, it would be Dilantin.
Dilantin, right. So Dilantin would be inappropriate for use in seizures. And our mainstay would be what, Nancy? Benzos. And our favorite benzo is what? Ativan. Okay, we'll get to why that's important. Importantly, propofol is good for alcohol withdrawal. Barbiturates we typically don't use because of side effects. Beta blockers we typically don't use. Alcohol, whether it be infusion or PO, is controversial. We won't talk about that today. Alpha adrenergic agonists, we use those as well. The latest, greatest of which is Precedex. And then, of course, neuroleptics, HALDOL. Basically, benzos stimulate GABA. They don't affect the NMDA. They decrease the severity, they decrease delirium, and they may even prevent seizures. Basically, adverse effects are hypotension and respiratory depression. Multiple agents, as Nancy said, we typically use Ativan as our agent of choice. They're equally effective in equivalent doses. You want something that's a rapid onset. In patients that are elderly or have hepatic dysfunction, you want it to be short-acting, okay? You don't want them all to be short-acting, though, because you want to avoid breakthrough. You want to avoid seizures. You want a smooth withdrawal. So that's where the different agents come in. So basically, you've got Ativan, you've got Versed, you've got Valium, and you've got Librium, okay? So our agent of choice in the ICU is Ativan, because you can give it IV, because it's you can give it as continuous. It's got a fast onset. Duration is about intermediate. You can also give Versed, okay? But one of the side effects, just like Ativan, is breakthrough symptoms. Valium lasts a lot longer, and it's not available as a continuous IV drip, so it's not really appropriate in the ICU. Librium, which we use in the IMU, is more of an intermediate onset, long-lasting, but it's only available as PO. So if you're in the ICU and you're not taking PO, or you've got fluid shifts and you don't know what your absorption is going to be, it's a bad choice. So really in the ICU, we should be using Ativan. And if you can't use Ativan, then maybe Versed. Just some commonly used doses. Some comments on propofol. We typically talk about not using propofol in trauma patients. That being said, propofol is a really good agent for those patients that have alcohol withdrawal in spite of benzos. It not only stimulates the GABA receptors, but it inhibits NMDA. Its effects are essentially the same thing as benzos. And once again, useful if the DTs are refractory. The other good the advantage is that it lowers ICP. Okay, similar side effects. So Mike, have you heard of propofol infusion syndrome? Have you heard of propofol infusion syndrome?
He's in the ER, doesn't have that often.
No.
Okay, Josh, what's propofol infusion syndrome?
It takes longer, and it takes a little bit longer than Mike would see in the ER.
Okay.
It's essentially somebody who sort of develops a sympatho-resistant syndrome where if they were to have a hypotensive cardiac arrest, it would be very difficult to resuscitate them with the vasoactive drugs.
So that's exactly it. That's sort of the end point. But basically, propofol, whether it be the actual agent or the carrier, affects mitochondria. And it may be acquired or congenital that the mitochondria can't process what's in the propofol. And so basically, organs that rely on high mitochondrial activity, the heart, the liver, muscle, start to have dysfunction. So you get a fatty liver, you get rhabdo in the muscle, which causes renal failure, which causes acidosis. You get myocardial dysfunction, and you can actually get bradycardia and asystole that don't respond to our usual agents. And once that happens, I think you can pace them, but that's about it. So propofol we use a lot, but watch out for it.
But does that last just as long as the propofol? Because it's such a quick on, quick off drug. You just stop the propofol with how long does it?
You don't want it to happen. I'm not sure how long it typically lasts, but I mean, you've got somebody coding. It just you gotta.
Okay, well, I'm saying, is it the drug that's causing it? The drugs that's causing it in such a short half-life.
It's the drug and the resultant mitochondrial dysfunction.
He's asking,
But how long
of it, yeah.
is it dysfunctional? So I'm saying, if you stop the drug, does it?
I don't think it's well studied. I think if you stop it, it should go away. But if you get to the point that, they're in asystole, it's sort of past the point. HALDOL, basically, it decreases the severity of alcohol withdrawal. It doesn't decrease delirium. It doesn't prevent seizures. It's not recommended as a sole agent. So HALDOL. So if you've got somebody in alcohol withdrawal and you give them Ativan, it doesn't work. Jackie, what do? You give them some Ativan, it doesn't work.
You can try some HALDOL with the Ativan.
You can. So I give them 2 of Ativan. That doesn't work. So the next thing is to give them more. And so Ativan doesn't work, you give them more. And if it doesn't work, you give them more. So you don't give one of agent and then switch over. So the alpha-2 adrenergic agents. So clonidine is the classic agent that we talk about. And basically what you do is you stimulate the central alpha-2 receptors and thereby cut down on the hyperexcitation. The problem with this is that it's not very selective for central versus peripheral, so you can get a hypotension. And the other thing is it decreases seizure threshold. It's difficult. There's no IV formulation, so you either give PO or you give a patch. So for the reasons we talked about with respect to Delirium, clonidine is not a great choice. So then you have Precedex, and so that's kind of the latest, greatest. It's a sedative, it's an analgesic, it's sympatholytic. It gives you that calm, cooperative patient we talked about earlier. It's got a rapid onset, easy to titrate. It's got a much greater affinity for alpha-2 in the CNS than does clonidine. There's predictable side effects, bradycardia, hypertension. We all know about the loading dose and maintenance dose. Its use in alcohol withdrawal is only in animals in case reports. There was one case report in 2008, but there's very little out there. There's definitely no studies. But there is a thought that theoretically this should work, and so there's a lot of buzz about using this. All right, now we're going to talk about protocols. So basically, as we talked about in the beginning, so Siobhan, so you were at the beginning, right? So, okay, so we talked about at the beginning that less than 50% of trauma surgeons surveyed have a protocol for diagnosis. Only about 2/3 have a protocol for treatment. And so the thought is that protocol is going to be much more effective than not having a protocol. There's different ways the protocols go. There's different measures that one uses. What I'm going to do is I'm going to present one from the literature as an example, and then talk about our protocol and that we have in place now, just to increase the familiarity with it and kind of where we can go from there. So Stanley in 2003 did a pilot study and wanted to use a practice guideline to use a symptom-triggered approach. And the thought was that by using a protocol, they would decrease the overall use of benzodiazepines. They wouldn't undertreat the delirium or undertreat the hyperactivity. There'd be a shorter length of stay and less need for sitters and restraints. So basically, 38 prospective patients falling into the categories that we would like to talk about, so trauma, orthopedic, general surgery. They used one in particular unit that had trained the staff on that unit, which is a key feature. They used a CAGE score, used an H&P, other historical things, particularly up to 6 drinks per day, so that's pretty impressive. They compared this group, in which they used a protocol, which I'll talk about, to a retrospective group. They excluded patients that were particularly sick. So we talked about the CIWA scale. See, Nancy, what does CIWA stand for?
Forgot.
Okay. Gabby. Josh.
I've seen it 3 times. Something about withdrawal algorithm. Center, I can't remember.
Mike.
Something institute withdrawal algorithm.
It was just a real busy slide.
Right, this way.
It was a real busy
I actually looked at it and said you were going to ask somebody and try to remember it.
Anybody?
Withdrawal of alcohol.
HALDOL or withdrawal?
Clinical Institute Withdrawal Assessment.
I got 3 out of 4.
That's pretty good, actually. That'd be passing. So that's what we use. But as I talked about, that's sort of considered the gold standard, but it's not really based upon a lot of good data. So this particular institution used what they call an AWS indicator, and I think in the literature, those are the 2 that I see the most. And basically, they broke their assessment and symptoms into 3 categories. So type A was the central nervous hyperexcitation. Type B was the adrenergic hyperactivity, and type C was the delirium. And basically, based on the 3 different symptoms, they treated with 3 different meds, which made sense mechanistically with the symptoms. So Ativan for type A, clonidine for type B, HALDOL for type C. Average patient was a 44-year-old man. They found that using the treatment protocol that they had set up, which was fairly complex, it required less benzodiazepine. They used more clonidine, less HALDOL. They commented that they had fewer sitter hours and fewer restraint hours. That being said, they were assessing the CIWA frequently. And so the staff was really busy. So although they said they used the sitter less frequently, the nurses were more involved. There was no difference with respect to seizures. There was no difference with respect to cardiovascular events. There was no difference with respect to transfer to the ICU or length of stay. And the other comment they made was compared to the retrospective group, about 30% of those in the protocol required no drugs at all, just assessing them frequently, versus only 10% of those that they would treat without a protocol. Problems, small numbers, different patient populations. They compared it to a retrospective group. As I talked about before, very labor intensive, so frequent monitoring. And the other thing is that both the MDs and the nurses were inconsistent in how they upheld the protocol, and also with the retrospective group. So that's one example of sort of an approach and findings on protocol. The protocol we've put in place here is fairly straightforward. And so basically, it's supposed to start in the trauma bay, where there are placards in the printers, so I hear. And we have the following inclusion criteria. So they've got to either have a positive blood alcohol, they've got to have signs of intoxication, or a significant history of alcohol use and withdrawal in the past. And a little caveat to that, as we talked about, is they've got to have recent alcohol use. So saying they were an alcoholic, in recovery for 10 years probably wouldn't qualify them. Exclusion criteria, what is somebody that we're using our CIWA scale, what do they have to, besides current alcohol use, to be a legit patient to use the CIWA scale? Josh?
They have to have ability to speak.
So be able to verbally communicate. So mechanical ventilation is out, okay? Head injury is out. Remember we talked about the differential diagnosis and attributing things to alcohol withdrawal that were indeed due to something else. Somebody's got a head bleed. It's a much more difficult decision tree as to whether it's alcohol withdrawal or the head bleed. So using a protocol is probably questionable in that case, so we don't do it. The other thing is the IMU, okay? And why don't we use our protocol in the IMU?
Why don't we use it? I mean, we don't really assess that often either.
Okay, so I need to clarify this because I've actually been told by the IMU charge nurse that they've actually been in service on this.
No, that is not true. I clarified
Because
that
I'm getting different stories from every single person I talk to.
I think you talked to me. We have not been.
No.
At all.
Because someone was telling me they were using it, and I didn't realize the IMU was in service, and so somebody told me that they were.
What has happened is we start to use that on a patient in the ICU, and then it gets continued over, and so the IMU nurses are like, "What's this?" And so as you'll see, the protocol is set up so that it's very labor intensive, and the data system that we have in our ICU allows the ICU nurses to do it. The nurses in the IMU don't have that same data system, so they have.
I'm just telling you that there are some nurses out there who think that they can do this, so just be aware.
Okay. So part of this is to spread the word to not.
Protocol?
No, it shouldn't be used.
But
The idea is that it starts this starts simple in the ICU. We work through the bugs, and then it gets expanded, perhaps to be a little more complicated, and becomes hospital-wide. But for now, it should only be in the surgical ICU, and that's it. So, using those inclusion and exclusion criteria that will be up in a placard, where not only the trauma nurses but the trauma residents will be able to pick patients out and be reminded of it. If you have somebody who meets criteria, physician responsibilities. There's nothing really different from what we normally do. There's one difference. So you give them an IV, you give them multivitamin, you give them thiamine, you give them folate, banana bag. We do that if patient's intoxicated. That should be automatic. You check serum electrolytes, automatic. In the process of coming up with a hospital-wide computer system, we've sort of gotten around that a little bit, at least for the pilot part of this, in that you go into your order set and you order Ativan, 1 milligram IV times 1 PRN. In the comments section, you write, activate alcohol withdrawal protocol. Okay? By doing that and putting it in the orders, the pharmacy sees it because it's a drug that you're ordering and it's in the comment section. The ICU nurse sees it because it's an order. So within the pharmacy order set for our ICU, they've got an alcohol withdrawal protocol that they can then activate. So the pharmacy knows to do their thing. The ICU nurses know, okay, we've got the CIWA scale in our computer. We're supposed to do this. And they go from there.
It'd be nice in the future if it was actually part of the computer admission program, like, is the patient on a beta blocker, all the other stuff people do, because truthfully, as much as I hate taking decisions away from physicians, this is almost something that should be done automatically if certain criteria are met. And
then that's actually the plan, but to get through PCIS and get it approved is more difficult. So the protocol itself that I alluded to, that the SICU nurses in the pharmacy in the ICU has access to, is that they measure a CIWA scale, and they've got a drop-down menu that they answer questions. Remember, 7 out of 10 of those require the patient to be able to communicate. And then based on the CIWA scale that you'll see, you administer Ativan. Pharmacy has that. And then depending on what the CIWA was, it tells the nurse when to go back, check the CIWA again. So if this, do this, recheck now, and it just goes like that. Okay? Some various call MD orders. So if they're febrile, if they're hypertensive, if they've got those autonomic hyperactivity things that may not be responsive to the Ativan or may require the addition of an alpha adrenergic agent, agitation, confusion, things that may require HALDOL, and then of course the CIWA greater than 25 would imply that you probably need to go above and beyond what this protocol is. This is for early on patients to prevent it from becoming late. So we talked a little bit about a little background physiology. Anybody remember the technical name for hangover? Myalgia. Okay. So remember alcohol withdrawal syndrome, alcohol withdrawal delirium. We probably shouldn't be using the term DTs. Okay. Presentation, differential diagnosis, and once again, I watch death. CIWA scale, clinical, institute, withdrawal, assessment, treatment, benzo, maybe add on HALDOL, maybe add on in the future Precedex, and then protocols. We have our own, but it's not the only way to do it, ours is a pilot that hopefully will eventually become hospital-wide. Questions?